Hey everybody, good afternoon. Hope everybody's doing great on this Monday. My name is Bill Ikest. I'm a longtime member of the Georgia chapter of HFMA. We're going to give folks just a couple minutes here before we get started. We've got some people coming in. Want to make sure we give everybody time. Hi everyone, we'll get started here in just a minute. Sandra, can you just confirm for me that you're able to get on? I see you're on mute. Can you just confirm for me that you can hear the audio? I see it shows that you're on mute. Folks, we'll get started here in just a minute. Sandra, can you hear me now?
She said she can hear you. I think she's on the attendee side, I believe.
Okay, let me try to. Let's see. Yeah, we may have Marlene as a presenter and you as a presenter, Charles. So hang on just a second. I will. Marlene, are you able to hear us? Marlene, are you able to hear us? Well, good afternoon, everybody. My name is Bill Ikest. I'm a longtime member of the Georgia chapter. I want to welcome you to the 2021 Spring Payer Forum for the Georgia chapter. I'm so sorry that we can't be together in person. We have certainly enjoyed over the years having this event, but we think it's very important to continue encouraging a relationship between the payers and the providers in the state of Georgia. So what we've done, as many of you have already signed up for, is asked some of the primary payers in the state to participate this week. And today we have Palmetto GBA. So I want to thank Sandra Booker and her team. They've always been so cooperative and so helpful in helping us by participating in this event. And she brought some of her colleagues with her today. She's got Marlene Frierson, Charles Kanan, and Emily is also with us, who maybe have some time to get into an appeals demonstration that Palmetto GBA is offering. So if you have any trouble hearing me or hearing anybody, would you please put a note in the chat so that we're aware that you're that you may be having trouble hearing or whatever. I hear that you can. Andrea says she can hear me, so that's a good thing. All right. Got a good number of people with us today. I just wanted to take a minute. The page that's up on your screen is those organizations that are corporate sponsors of the Georgia chapter of HFMA, and we just want to thank them for their support during this challenging time. Many of you may have plans to attend the Georgia HFMA Spring Institute, which is coming up May 5th through the 7th in Atlanta. In Callaway Gardens down in Pine Mountain, Georgia. It's our first back in-person event, and we're looking forward. I hear the turnout for that has been excellent. So if your organization is allowing you to, and if you're comfortable enough traveling, we would love to see you down there. It promises to be a great event. So without any further ado, let me go ahead and get this started. I'm going to change what I'm sharing. And Marlene, can you hear us okay?
Yes, can you hear me?
I can. Did you need for me to drive the presentation or do you have it on your end? I'm happy to do it.
No, I think you're going to have to drive because I don't see that.
That's fine.
The other thing. Okay.
No problem.
Thank you.
Happy to do it. Let me pull it up here for you. It's in a PDF, so I just want to make sure we get it where people can see it. So you just tell me when to change the screen, okay?
Okay.
Yeah, great. So I'm going to turn it over to Marlene. I assume you're first. I'm going to turn it over to you, and you can go ahead and get started.
Okay. Yes, I'm trying to navigate this without two screens, so
Right.
It's going to be interesting.
Right. I would tell one last housekeeping item. I would tell folks if they have questions for Palmetto GBA, please put those in the Q&A section, and I'll present those to the presenters as we go along. So thank you for that. It's all yours, Marlene. Thank you.
Okay, thank you. As Bill stated, I am Marlene Frierson with Provider Outreach and Education with Palmetto GBA. We're going to go ahead and get started. As we all know, there are a lot of COVID-19 changes, so I'm going to be addressing that with you, but let me first go over the disclaimer. The information that's provided in this presentation was current as of April the 15th. Any new changes or new information will be provided in articles and publication dates after April 15th and will be posted on our website at www.palmettogba.com/Medicare. Next slide. As I just stated, we're going to go over some COVID-19 updates. And then one of the other things that we're going to review is comprehensive error rate testing, which we normally call CERT. I'm going to provide a few updates for that for you. Next slide. Okay, as we all know now, it's hard to believe we're still in this, but we've gone through this a full year now, and it just seems like it's not going away. But as background, we're going to recap just a little bit as we discuss flexibilities to address the spread of the 2019 novel coronavirus disease, COVID-19. CMS aggressively took action in exercising regulatory flexibilities to help healthcare providers contain the spread of the virus. CMS took proactive steps by achieving blanket waivers, and there's a link for you there, with a retroactive effective date of March the 1st, 2020, through the end of the emergency declaration. And I know you all, like me, you're ready to get to the end of that declaration. Next slide. And with that, of course, we know we have the COVID-19 vaccines that are adding new measures for prevention. There are some that are in development. As you already know, the FDA has emergency use authorization, which is a process that helps facilitate the availability and use of medicines and vaccines during the public health emergency. And then those vaccines, we just want you to realize, or CMS really wants you to know, that those vaccines are being held to the same safety standards as all vaccines. Next slide. On the monoclonal antibody COVID-19 infusion program, on November the 21st, 2020, the FDA issued an emergency usage authorization, an EUA, for the investigational monoclonal antibody therapy, and I'm not going to try to describe those drugs, administered together for the treatment of mild to moderate COVID-19 in adults and pediatric patients with positive COVID-19 test results who had a high risk for progressing to severe COVID-19 and/or hospitalization. During the COVID-19 public health emergency, Medicare will cover and pay for these infusions when furnished consistent with their respective EUAs, the same way it covers and pays for COVID-19 vaccines. Healthcare providers administering the COVID-19 monoclonal antibody infusions will follow the same enrollment process as those administering the other COVID-19 vaccines. Next slide. Now, with that, we have some general COVID-19 coverage items that I just want to cover briefly. Medicare covers the lab tests for the COVID-19, so there are no out-of-pocket costs for the beneficiary. Medicare covers the FDA-authorized COVID-19 antibody test if diagnosed with a known current or known prior COVID-19 infection or suspected current or suspected past COVID-19 infection. As we just discussed, they cover the monoclonal antibody treatments. They cover the COVID-19 vaccine, so there are no out-of-pocket costs there. Medicare covers all medically necessary hospitalization. This includes patients who are COVID-19 diagnosed and might otherwise have been discharged from the hospital after an inpatient stay, but instead the patient needs to stay in the hospital under quarantine. Patients still responsible for the hospital deductibles, copay, or coinsurances that apply, but they do allow that to be a hospitalization if the patient needs to remain there for quarantine. Next slide. Now here, what I have for you is the top link you see pasted at the top of this slide links to a YouTube video on how to enroll in Medicare to administer COVID-19 vaccine shots. Please watch the video, but for time's sake, I'm just going to provide a quick summary for you. Green, if you are already currently actively enrolled in Medicare as a non-institutional provider, no action is needed at this time. You just bill the COVID-19 shot or monoclonal antibody infusion therapy through individual claims or roster billing. Yellow, if you are enrolled in Medicare, but your provider type doesn't allow you to bill for administration of the vaccine, you must also separately enroll as a non-institutional provider type, such as a mass immunizer, that can bill for the COVID-19 shot, and monoclonal antibody infusion therapy. Red, if you're not enrolled at all in Medicare, which I'm sure that's not any of you guys, but if you're not a Medicare provider, or you know someone that is not, they must qualify and enroll as a mass immunizer or other Medicare provider type that allows billing for the administering of the vaccines so that you can bill for administering the COVID-19 shots and or the monoclonal antibody infusion therapy. Details of the information is also listed on the CMS dedicated web page that they have on their website, which is www.cms.gov, but there is a particular section there regarding the enrollment information for Medicare, and that link is pasted there at the bottom of the slide for you. So just click on your appropriate scenario if you need additional information. If you're already enrolled, if you're enrolled but you're not at that particular provider type, you need a different provider type to allow you to bill for the administration of the vaccine. Or if you're not enrolled at all, any of those scenarios, if you click there to give you the appropriate steps. Next slide.
Marlene, let me interject there just real quick.
Sure.
So people might be asking about some of this information. So what I was going to say was at the end of the presentation today, I'm going to provide for them how to access the presentations later on in the week, so they'll be able to have this information. So just wanted folks to feel comfortable with that.
Okay, thank you.
Uh-huh.
And if we can help you with the specific links, just let me know. But you should have access to that, Bill.
Yeah, we should be good. Thank you.
Okay. All right. So next slide. Yeah, we're there. Okay. So then the next thing that we're going to review is the coverage and billing for monoclonal antibody products to treat COVID-19. And that's what I'm going to go into next. Okay, next slide. Expected payments to the provider. So let me point out a few coverage facts. Medicare will pay the provider for these monoclonal antibody products when they are purchased by the provider. Medicare won't pay if the product is given to the provider free, for example, by a government entity. So they have to be purchased in order for Medicare to pay the provider for the monoclonal antibody products. If you receive them free, you cannot receive any reimbursement for that. Okay, when purchased by the provider, Medicare payment is typically at reasonable cost or at 95% of the average wholesale price, and that amount is determined by the manufacturer. These payment amounts vary depending on which type of provider is supplying the product. Fee-for-service Medicare will pay for these products for beneficiaries enrolled in Medicare Advantage programs. Next slide. And these are some toolkits for you, basically some resources. CMS released a set of toolkits for providers, states, and insurers to help the healthcare system prepare to swiftly administer the vaccine. These resources are designed to increase the number of providers that can administer the vaccine and ensure adequate reimbursement for administering the vaccine in Medicare, while making it clear to private insurers and Medicaid programs their responsibility to cover the vaccine at no charge to beneficiaries. In addition, CMS has taken action to increase reimbursement for any new COVID treatments that are approved by the FDA. And there's a link there also that'll provide some of that information for you. Next slide. Okay. So how do you bill for the COVID-19 vaccines and the monoclonal antibodies? Well, you're going to bill single claims for vaccines and antibodies by following the instructions that are listed here for you. You can roster bill, centralized billing, and you just reference the Medicare billing for COVID-19 vaccine shot administration page. When COVID-19 vaccine and monoclonal antibody doses are provided by the government without charge, only bill for the vaccine administration. Do not include the vaccine codes on the claim when the vaccines are free. If the patient is enrolled in a Medicare Advantage plan, submit your COVID-19 vaccine and monoclonal antibody infusion claims to Original Medicare in 2020 and 2021. These codes will not apply to skilled nursing facility consolidated billing edits. Okay, next slide. And these are your type of bills that need to be reported for the COVID-19 vaccine and monoclonal antibody infusion on your Part A claim form or the electronic equivalent. So you have your inpatient Part B, your hospital, which is going to be your 12X, your SNF, which is going to be your 22X. You have your outpatient, you got your hospital at 13X, the SNF at 23X, end-stage renal disease at 72X, and then your comprehensive outpatient rehabilitation facility, your CORF, at 75X, and then your critical access hospital at 85X. Next slide. You're going to have your revenue codes that you must use for your COVID-19 vaccines and the administration billing. So you're going to have a revenue code of 0771, and then, a revenue code of 0636, and you can see the descriptions there. The COVID-19 vaccines and monoclonal antibodies, and that is a link there, and we'll make sure you have that information. They have a web page that provides payment allowances and other information, including your CPT codes, under payment allowances and effective dates for COVID-19 vaccines and their administration during the public health emergency. And we have this listed several times. Just remember that you should not bill for the product if you received it free. And I also mentioned that there's an article on our webpage that shows you the type of bill, the revenue codes, and the different scenarios and how to bill for the vaccines and the administration. Next slide. That article also provides for you the condition codes and diagnosis codes that must be present for this billing. So for the vaccines and administration, you must have a condition code of A6 or 78. And as you see on the side note there, 78, that condition code 78 is billed on claims for Medicare Advantage beneficiaries only. Then you have a diagnosis code of Z23, and that code must be included when reporting an encounter for the COVID-19 vaccine or the monoclonal antibody treatment. And there's a note there, for vaccines provided for inpatients, use the date of discharge or date Part A benefits exhausted as the date of service. Okay, next slide. Now on this one, it's going back just a little bit, but it's still giving you the revenue codes of 0771. And here, per CMS, although there are more accurate revenue codes available for reporting of these infusions, the current guidance is for providers to utilize this code to report the infusion until further instruction is issued. So continue to use the 0771. The 0636 is for your pharmacy drugs requiring detailed coding. Monoclonal antibodies and administration codes are under payment allowances and effective dates for COVID-19 monoclonal antibodies and their administration during the public health emergency. And it'll show you some payment allowances underneath that article. Next slide. And just as detailed, per CMS, modifier CS is not required to be reported when billing instructions are utilized, as the Part A systems have been updated to ensure there is not cost share for patients for COVID-19 vaccines or monoclonal antibody treatment. Note, the drug should be reported with the revenue code 0636, and the administration infusion should be reported with revenue code 0771. And then as far as the condition code 78, that is new coverage not implemented by Medicare Advantage, so you would bill that again only on claims for Medicare Advantage beneficiaries. And then we have your diagnosis code, which we've already reviewed. But per CMS, that Z23 must be included when reporting an encounter for the COVID-19 vaccine or monoclonal antibody treatment. And this note for vaccines provided for inpatients, use the date of discharge or Part A benefits exhausted as your date of service. Next slide. Now for your rural health clinics and federally qualified healthcare centers. So independent and provider-based rural health clinics and federally qualified health centers do not include charges for the COVID-19 vaccine and monoclonal antibodies on a claim form. Administration of these vaccines does not count as a visit when the only service involved is the administration of the COVID-19 vaccine and or the monoclonal antibodies. If there was another reason for the visit, then the facility should bill for the visit without adding the cost of the vaccine and or the monoclonal antibodies to the charge for the visit on the bill. Payment is made at the time of cost settlement. Next slide. So for SNFs and their billing, In order to facilitate the efficient administration of COVID-19 vaccines and monoclonal antibody treatments to SNF residents, CMS will exercise enforcement discretion with respect to these statutory provisions, as well as any associated statutory references and implementing regulations, including as interpreted in guidance of the SNF consolidated billing provisions. Through the exercise of that discretion, CMS will allow Medicare enrolled immunizers, including but not limited to pharmacies, working with the United States to bill directly and receive direct reimbursement for the Medicare program for vaccinating Medicare SNF residents. So there is a little discretion that they're allowing there for SNF facilities, or SNFs, I should say. Next slide. Make sure we're matching. Yes. Okay, so coding for the monoclonal antibody COVID-19 infusion, CMS identifies specific codes for each monoclonal antibody product and specific administration codes for Medicare payment. And Medicare payment for the infusion, in order to ensure immediate access during the public health emergency, Medicare will cover and pay for these infusions in accordance with the CARES Act. CMS intends to address potential refinements to payment for COVID-19 monoclonal antibody infusions and the administration through future notice and comment rulemaking. So basically, stay tuned. Get the most up-to-date listing of billing codes, payment allowances, and effective dates at those resources that's listed there for you. And please remember the toolkits, and you can always get to those toolkits from our website as well. Next slide.
Marlene, can I interrupt with a question?
Yes. Please.
So we had a question that came in that the attendee says, we have some accounts that the patient has where the patient has a Medicare Advantage plan, and we bill the monoclonal antibody 636,771 charges to the traditional Medicare. They are either RTP'd or rejected, saying that the patient has the Medicare Advantage plan. How do we handle these?
Okay, somebody needs to review that. So let me think on that one and figure out the best way to get those examples and take a look at that.
Now,
Can we get some examples?
There is a slide that talks about you have to put certain information if there's a Medicare Advantage patient, and I think that slide is coming up, so that may answer her question.
Okay, yeah, let's wait and see. I'll monitor the chat to see.
Okay, thanks, Charles. Okay, so as a payment reminder, and let me see, make sure. Can you go to the next slide for me, Bill?
Yeah, I'm sorry.
No, that's no problem. Okay. As a payment reminder, Medicare will make payment to those providers or suppliers for the monoclonal antibody product to treat COVID-19. Again, whenever you pay for it, you cannot have received it free, and it will make a separate payment for the administration. They will not provide payment again as long as if you receive that. I'm sorry, my mind went someplace else. You will not receive any reimbursement for that, but we will cover and pay for those infusions the same way it covers and pays for the vaccines. And let's see, I think that slide is coming up that we were talking about. The next slide, can you go to the next slide, Bill? Mm-hmm. Yes. So for the Eli Lilly and Company's antibody, and again, I'm not trying to pronounce that, the EUA effective November 10th, 2020, you have the Q0239 and you have the M0239. So CMS has identified these specific codes for each monoclonal antibody product and specific administration codes for Medicare payment. Next slide. For Regeneron's, we have the Q0243 and that was effective November 21, 2020. You have your long descriptor and short descriptors there, and you have the M0243, which is additional coding for the monoclonal antibody infusion. Okay, so next slide. And I had to put this in there, and this could change as of tomorrow, who knows, but still currently, we all are aware that Johnson & Johnson, that vaccine, the CDC has issued a health alert. And basically, to ensure that the healthcare provider community is aware of the potential for adverse events and provide proper management due to the unique treatment required for the type of blood clots, they have issued an alert, which includes specific recommendations for clinicians. So let's just be aware of that. Next slide. This provides the CMS links for you as far as the different instructions, the coding, the Medicare payment for monoclonal antibody infusion, your administration, and your updated codes, etc. There's a link for the enrollment if you want to be a roster biller, etc., or depending on your provider type, as we discussed on the slide, and then the vaccines themselves. Okay, next slide is additional resources and your toolkits for medical centers, clinics, and clinicians, some frequently asked questions, some fact sheets, etc. There's one there specifically for SNFs, and the toolkit on health insurance and Medicare Advantage plans. Bill, I think what I'm going to do, because if I remember correctly, the question is about the Medicare Advantage plans, and it's the claims are returning with the correct revenue codes. Is that correct?
Yeah.
Okay. As Sandra's going through that, I'll look for those details when she starts doing her section.
Okay.
I don't have much more.
Yep. Sounds good. Gosh, safe to say that you've become an expert on monoclonal antibodies through all this?
No.
Goodness. At least billing for them. At least billing for them. I did have another question come in. Is there any guidance on billing for remdesivir in the outpatient setting, the drug or the infusion?
Remdesivir, the drug on the outpatient setting?
In the outpatient setting, correct.
I'll look up that one as well.
All right. We come back to it. Okay, so we're turning it over to Sandra now.
I know I have a few more slides, and then we'll.
I just want to make sure I unmute her.
Okay, I had to jot that down real quick. So that was revenue code 0771 and 0636 that they're receiving an RTP for the Medicare Advantage, and then someone's asking about remdesivir outpatient, correct?
Correct.
Okay, nope. The next section is totally different topic, CERT. So if you would go to that slide for me, this won't take long. This is the comprehensive error rate testing. Now CERT is a separate contractor, and I'm just going to review some things. There are a couple of updates that we just want to bring to your attention. So next slide. As just wanted to remind you all that what CERT is and its purpose. Basically, CMS calculates the Medicare fee-for-service improper payment rate through the CERT program, which is a separate contractor. Each year, CERT evaluates a statistically valid, stratified, random sample of claims to determine if they were paid properly under the Medicare coverage, coding, and billing. A lot of times they ask for additional information, and next slide. to get to that. And so basically the contractor responsibilities, and this, we just kind of want to remind you, if you get a call or if you see a request, that we, even though the CERT contractor is the one reviewing and doing the calculations and reviewing the information, we as a Medicare contractor make courtesy calls because we're just as responsible for our CERT error rate as that they're calculating. So we will be giving you, sometimes you guys may get calls that say, just a courtesy call reminding you to submit some records, etc. So the contractor responsibilities, we help to identify the improper payments, submit claims to adjustment to the max. So we want you to submit those claims when the errors are identified. There's no error identified, then no action is taken. Please respond to any audit-specific questions you may have, such as the rationale for identifying potential improper payment. Next slide.
Marlene, Sandra messaged me and said that on the Medicare Advantage plans for Part A claims, be sure to include condition code 78 for Medicare Advantage plans.
Thank you, Sandra.
And Christy, I hope that answers your question. If it does not, please follow up. So
there, in our reference, there's an article that will probably answer that for her quite easily. Okay. I just need to get to it.
Yep.
Okay. And then for the CERT error reduction, so for your so errors requiring maintenance. In order to have successfully paid claims, provider must conduct maintenance. Self-audits will decrease common error threads that weave through the system, causing a disconnect between claim submission and claim payment. So please use your CERT tools that are available on the Palmetto GBA website to help you facilitate through that. The next slide. Please appeal your CERT errors. If you receive a CERT error, review the error and the submitted documentation. Appeal a denial and include any additional information that supports payment of the claim. That's imperative. Providers may not correct or change a CERT error claim and simply resubmit the claim if they disagree. Please appeal your claim. Next slide.
Hang on if I could. I just have some follow-up from that Medicare Advantage inquiry. So even if they have a Medicare Advantage plan and we're billing those charges to traditional Medicare, are we supposed to add the 78 condition code as well?
I tell you what, let me go ahead. I was gonna make sure that that's included in the link.
Yep.
I'm gonna find the article on our website, and I think that's gonna answer, and it'll make it will make it a lot easier for everyone.
Okay.
Just bear with me.
It's okay.
So if you go to JJA, under, that's CMS Toolkit, COVID-19. And okay. Wow, I knew we had a lot here. Okay, I tell you what, I'm going to find it, and I'll bring it to there. That's going to answer the question for everyone.
Okay, great. Go ahead. We can keep moving, and we'll circle back on that.
There we go. Okay, so on your CERT errors, again, if you receive a CERT error, please appeal that. If you'll go to the next slide, Bill. Oops,
sorry.
That's okay. So we just kind of want you to use what's out there on our website and be proactive. If you use a tracking system for your medical record requests so that you can log each request and note the due date, review the request, pull the records, use a list that are available on our website, review the records, and authentication. So we just want you to take a proactive approach to the CERT. Please appeal, because we want to make sure we anything that is that can be appealed, you go ahead and do that. And that'll assist everyone. Okay, and just a couple of updates. If you go to the next slide, Bill. Basically, what I'm going over right now is just some system updates. It's not, there's a new program. The program is the same, but they've changed the software. If you go to the next slide, yep, you see that? That is a screen print. It's now called, what you'll hear is referred to as the C3 Hub. So welcome to the CERT C3 Hub. They've changed the system. All right. Then on, if you go to the next slide, what has not changed? Well, the process hasn't changed. The reason for the improper payment determines the error category for the claim. Those have not changed. The 5 major error categories: no documentation, insufficient documentation, medical necessity, incorrect coding, and then they have an other category. But the process itself has not changed. CERT will send an initial request letter for records with up to 3 more letters and or phone contacts to obtain medical records. If not received, they will request that the MAC recoups the funds that were previously paid. During the review process, CERT will send a letter and or contact the provider if there's missing documentation needed to avoid a payment error. If an error in payment is identified, CERT will notify the MAC and the claim will be adjusted according to the error reason. As with any type of error, the provider can appeal the decision by the MAC by submitting a request for reconsideration. Next slide. The number one error, and I know you're really surprised about this. I'm being really facetious when I say that. As always, the number one error, I think that it goes pretty much across the board, is that the documentation is not submitted. So the number one error is not submitting documentation or not submitting sufficient documentation. So providers are not providing, especially on ADR requests, whenever they submit any type of additional documentation request, that is not being submitted to support the bill claim. Providers are only including documentation for the bill data service, and sometimes they want, well, not sometimes, they need to know the story. So if the story is not there for them, they're going to call it an error. Other top errors are due to documentation not supporting medical necessity and incorrect coding. For example, billing for the wrong or incorrect code. So those would be your major errors right there. So what we hope to change: lab tests denied due to no documentation of medical necessity. So know that an ICD-10 code is not sufficient, and no orders or intent to order services signed by the physician. You have your E&M visits recoded based on documentation not meeting all the element requirements. And then signatures illegible or missing from the required documentation to support services. So we hope to change that. And what can you do to change? If you go to the next slide, Bill. Thank you. Be aware of these requests and submit all documentation that supports the billing of the services. Ensure documentation is legible, especially your signatures. If the signature is illegible, submit a signature log. If the signature is missing, with the exception of orders, obtain an attestation for the document. Keep contact information up to date for your provider number in order to receive the request letters and phone contacts by the CERT contractor. Return the original barcoded cover sheet request letter on top of the medical records when submitting to CERT. That helps them immensely so that they'll know where that documentation, what case it belongs to. Next slide.
Marlene, let me just interject again real quick. So it's about 1:45. I just wanted to let anybody that needs to drop off at 2 o'clock know that the presentation, as well as the recorded presentation, will be posted in the Georgia HFMA website at www.georgiahfma.org under the media tab, under the In Case You Missed It section. There'll be a folder for the 2021 spring payer form, and that information will be in there in case you need to drop off with us at 2. And I think we're going to run a little bit long, so that's fine. Thank you.
Uh-oh, am I talking too much, Bill? I'm sorry.
Oh, you're good. You've got a lot of information to share. So this is why we brought you on, was we wanted to make sure everybody was up to date and had the latest and greatest. So we're happy to do it.
Okay, all right. Let me go back. I'm sorry. This is the last important thing. So for cert denials, please appeal those, and you can use the cert redetermination request form. Do not resubmit the claim. Denial decisions based on a review of medical records. The denial was based on a review of medical records. Therefore, claims for these services may not be resubmitted, but they may be appealed. So please appeal those. And if you go to the next slide, slide 42 there, Bill, the root causes of cert denials are documentation errors. So a valid provider's order, element of an order was not submitted, intent to order not submitted, and documentation to support the services were not submitted. Palmetto GBA encourages providers to appeal cert denials that may be received. The process is very similar to appealing denials received from the MAC by using a redetermined request form. Make sure it's completed in its entirety before submitting. And Bill, if you can back up for me, my team is greatly helping me out there. You know, it's kind of hard to talk and do all this at the same time. If you go to slide 15, slide 15.
Okay.
They have to make sure not only with the correct codes that we were talking about, the and revenue code 0771 and 0636. Slide 15 points out the condition code, the A6, and you must use the condition code 78 whenever you're billing for the Medicare Advantage beneficiaries. So that person that was asking the question,
yep,
they had to make sure they had the correct revenue code, correct diagnosis code, and make sure you use the condition code 78 for Medicare Advantage beneficiaries.
Yep. Okay.
And I think that answers that.
Okay.
And I'll start looking for remdesivir outpatient.
Easier said than done.
Exactly. And I think it's time for Sandra to go now.
Okay. Well, let me is it Sandra's turn? Is she picking up here?
Yeah. If
okay.
you go to slide
42.
Because the other slides were just right.
Yeah.
We talked about that. It's about the lack and the quality of the additional documentation. You have to write the full story. And I'm just giving you some resources there. And then, of course, we have the MLN Quarterly Provider Compliance newsletter, which helps healthcare professionals to understand, and that's slide 46, Bill.
Okay. And then it just shows me that she's on mute is all. And I'm trying to unmute her, but it's not letting me. It just says she's on mute. So let's see if she can.
Okay, well,
there you go. Yep.
Talking while you got her?
Got her.
Okay. All right. So if they'll review that information, it'll help you avoid common billing errors and other erroneous activities. And it points out the top issues for the particular quarter. So we're just trying to help everyone be proactive so that we can reduce those errors for you.
Yep.
And then Sandra's going to start on slide 47, and I'm going to look up that article and the remdesivir question.
Okay, very good. Sandra, can you hear me? Sandra, are you with us? I'm showing that you're off mute. So, Sandra, can you hear me?
If she can, I'll go on with hers.
I see that she's off mute. I just can't hear her.
I can't. Let me see.
Trying to see if she's messaging me. I'm sorry. Or message in the chat. Sandra, give me a chat if you're not able to hear. She says she can hear me.
Oh, okay. I know I had to click a button that said unmute on my screen. Do you see that, Sandra?
Yeah, she came off mute, I think. Yeah, we can hear her, or she can hear us, but she can't. She says she's not muted. Let me check. Let me just check one thing here.
Okay.
She just thought you were doing such a great job. She just thought you were doing such a great job. She wanted you to kind of keep going. You know?
Exactly. That's what it is. That's what it is.
That's what it is. All
I
right.
will move on with hers if I need to.
Okay. Yeah, Sandra, try again. Try to click that again, that unmute button. Pretty sure we had her set up as a presenter, but let me see if there's anything else I can do on this now.
Just par for the course, right? 2020,
That's it.
2021.
Yeah, it happens sometimes. Yeah, she's off mute on this end, so I don't know why. We'll
Okay.
Yeah, Sandra, check your phone and the screen with not just your phone, but check the screen within Zoom as well at the bottom. I'm sorry, I'm just trying to go through stuff that I typically run into. She says both are off mute. So yeah, she might need you to pinch hit for Marlene if you can. I'm sorry.
Okay, no problem.
So I'm on slide 46.
Okay. If you'll go to slide 47, that starts her section.
Yep, go ahead. I'm there.
And okay, and I'm just going to let everyone know that we have C2C, the QUIC, which is responsible for the Part A East appeals demonstration. Emily Barnes, we invited her with us today, so if you have any questions specific to the program, she will be happy to assist you. So we have her with us we collaborate with them on the Part A East appeals demonstration. So welcome, Emily. Emily is their outreach and education specialist, and we work a lot together with them on that. So Sandra is discussing the Part A East appeals demo. Next slide. And so I'm just going to review what is the Part A East appeals demo until Sandra can get it off mute. Give you a little background, talk about eligibility, the benefits of the program, and how to participate. Okay.
And Marlene,
so what is?
If you need me to fill in anything, just let me know. This is Emily. I'm with you guys.
Hey, Emily. Yes, I probably did a poor job of introducing you, but
you're fine. If you guys need anything, if you need me to fill in anything, just let me know.
Well, they may be tired of hearing my voice, but I'll go ahead with this. So, what is the Part A East appeals demo? The Part A East demonstration is a telephone discussion that takes place between the provider and the qualified independent contractor, the QUIC, to see if an unfavorable decision can be overturned for payment. The Part A East appeals demonstration, also referred to as the QUIC telephone discussion and reopening process demonstration, is an expansion of the durable medical equipment, the DME QUIC demonstration that was launched in 2016. Next slide. Just as background, on January the 1st, 2016, CMS launched a QUIC telephone discussion and reopening process demonstration to test whether further engagement between the DME suppliers and the DME QUIC would improve the understanding of the cause of appeal denials and over time result in more proper claim submission at the DME MAC level from suppliers participating in the demonstration. On May 1st, 2019, the demonstration was expanded to the Part A East Quick jurisdiction to include all Part A claim types within the MAC jurisdictions of H, J, K, L, M, and N, and home health and hospice related appeals within the MAC jurisdictions J6 and J15. The demonstration gives selected providers, suppliers the opportunity to participate in a telephone discussion with the QUIC and have claims pending at the Office of Medicare Hearings and Appeals, OMHA, reopened and resolved. The impact as of calendar year 2018, the reconsideration decisions issued after a telephone discussion had a 63% partially or fully favorable decision rate in more than 95,000 DME claims, which were pending in the ALJ, Administrative Law Judge, backlog, were reopened and resolved favorably by the QUIC as a result of this initiative. So it is a very good program. Next slide. Based on the success of the DME activities, CMS authorized C2C to conduct the activities in the Part A East Quick jurisdiction. And the telephone discussion process allows suppliers to discuss the facts of the case with a quick personnel and to submit any missing or critical documentation identified by C2C as needed to support a favorable resolution prior to the QUIC rendering a decision. This process also works to educate the supplier community on Medicare coverage policies, the root cause of denials, and any trends associated with documents that are critical to the outcome of an appeal. The appeal demonstration has two main components, which are the telephone discussion and the reopening process. Therefore, as a part of the demonstration, the QUIC is also conducting analysis on previously completed unfavorable reconsideration decisions dated on or after January 1, 2013 to identify potential appeals that can now be resolved favorably through the reopening process. Under this demonstration, the QUIC has the authority to conduct reopenings on previously adjudicated unfavorable claims that are currently pending ALJ assignment at OMHA and or unfavorable reconsiderations that have been decided by the QUIC but not yet appealed to OMHA. Further, the QUIC assists suppliers in submitting withdrawal requests to OMHA when through the course of the demonstration activities, the supplier determines that they no longer wish to continue pursuing appeals currently pending. This demonstration was initially planned for 5 years and scheduled to end December 31, 2020, and CMS issued approval for a 1-year extension on the existing demonstration activities. The demonstration is now scheduled to end December 31, 2021. Sandra?
Can you hear me now?
Well,
Can you hear me?
Yes. Yes.
Okay.
All right.
Well, I just I logged out and came back in.
There you go. Thank
Okay.
you so much for your persistence. I'm on slide 52, is that right?
yes, that's correct, Bill.
And
All right,
again,
Sandra.
eligible participants were for the Part A appeals for JH, jurisdictions H, J, K, L, M, and N, along with home health and hospice, jurisdictions J6 and J15. And reconsiderations for service determinations, hospital discharge reviews, and claims or providers that are already involved in another CMS initiative are not eligible for telephone discussions and or reopenings under the demonstration. So under the demonstration, the QUIC reviews reconsideration requests to identify appeals that may benefit from participation in the telephone discussion process. So if you're already participating in a CMS initiative, you won't be eligible to participate in this one. Okay, next slide. And with the benefits, if you're selected to participate in the demonstration, you'll have a chance to discuss the facts of the case, provide your verbal testimony. You'll be able to submit any missing and critical documentation that's needed to support a favorable decision. You'll also receive feedback and education on CMS policies and requirements and improve proper claim submissions. As well as for the reopening process, you'll receive notifications in writing if an appeal at the ALJ can be reopened, and an opportunity to send additional documentation on cases pending at the ALJ. Providers will receive a letter from C2C when their appeal is selected for participation. And eligible Part A providers can contact C2C if they wish to participate. So the unique part about this demonstration is if you already have an appeal submitted for reconsideration and you would like for it to be included in the appeals demonstration, you can contact C2C by mail, email, or fax to see if that particular reconsideration can be reviewed, and you'll be able to participate in this program. The next slide, please. These were the top 3 appeals categories at the reconsideration level for telephone calls that were held during the last quarter of 2020. There were drugs, end-stage renal disease or ESRD, imaging, and radiology. In the next few slides, I'll go over some of the common denials that were seen for each. Next slide, okay. For drugs, it showed denials were for evidence that did not support the increased frequency of dosage or that the dosage ordered was administered. The evidence did not support a covered diagnosis. The evidence was lacking documentation required by the LCD or NCD. So you want to make sure that you would provide documentation to support an increase in the units for the drug or drugs that were being administered, as well as documentation to support the diagnosis, and reference the LCD or the NCD to ensure that you're covering everything. And always let providers know it's a good thing to create checklists, and you can create your checklist by using your LCD or NCD. Next slide. For ESRD, the evidence did not support the necessity for more than 3 dialysis sessions per week. The treatment flow sheets were not submitted for review, and the evidence was missing a physician's order or the order was invalid. So if the patient is receiving more than 3 dialysis sessions in a week, you need to make sure that you include the documentation to support and justify the reason why the patient is receiving that extra dialysis treatment. Also, your flow sheet should also be included, and include all of your physician orders and make sure they're valid. Again, creating a checklist can be helpful to make sure you have all of the documentation and orders when submitting your claim. Next slide. For imaging and radiology, the evidence did not support a covered diagnosis or indication. The evidence from the physician or provider did not support medical necessity, and the evidence did not include test results. So for this, just provide the documentation that supports the diagnosis and the need for the services. Include your test results, and also orders are often missing. So be sure to include the orders in all documentation to help support your medical necessity. Next slide. For home health and hospice, the top claims were found unfavorable were for missing face-to-face, the clinical encounter note and or the documentation to support homebound status was not found, And to review more on the face-to-face, you can go to the link that's posted on this slide. Next one, please. Okay, the most commonly overturned denials. And what does this mean? It means that providers that agreed to participate in the Part A East demo or the PAE demo had a telephone discussion with C2C, and they sent the documentation that was required or requested to the C2C representative that they were working with one-on-one, and they were able to have their denied claims overturned and receive payment. And these were the most commonly denials that were overturned. Next slide, please. In preventing your denials, you can make sure you include the documentation to support medical necessity, any diagnostics tests, including the results, your physician orders, progress notes, review your LCDs and your NCDs, and create checklists. Next slide. Through December 2020, C2C determined that 12,972 potential reopening cases could not be reopened after documentation had been requested. These cases could not be reopened for various reasons, including OMA's inability to remand the case to C2C, documentation not provided by the provider, or the submitted documentation did not cure the denial. So the requested documentation was not submitted by the provider, accounted for 68.75%. The Medicare benefit program manual requirements not met, accounted for 7.88%. Medical necessity or not meeting medical necessity accounted for 5.43%. And the Code of Federal Regulation or CFR requirements not met accounted for 4.27%. The next slide, please. Just to give you some numbers to look at, Palmetto GBA had 2 providers that participated in the PAE demo on a continual basis from October 2020 through December 2020. They had a significant amount of telephone discussions and denials overturned for payment. The 3rd provider had denials overturned, but they did not participate during the month of November. Next slide. Some provider questions. Next slide, please. The telephone discussions are scheduled for 30 minutes. I don't have time for that. Why does it take so long? Well, on an average, the calls can take less time. C2C allows the full 30 minutes to ensure that each provider has enough time to discuss their appeal and for them to give as much verbal testimony as they possibly can. So don't let the allotted time keep you from participating, because it can go as fast or as slow as you would like. Next slide. Do we have to go over the regulations during the telephone discussion? Well, believe it or not, there have been providers that did not understand the regulation or did not know what regulations were used to make the decisions on their appeal. For this reason, C2C discusses the regulations during the telephone discussion. The recordings, of course, the telephone discussions are recorded, and they're recorded because they become a part of the official Medicare record associated with that specific appeal. And if for some reason C2C cannot allow payment and you appeal to the next level, the ALJ has access to the recording. So that's why C2C has to discuss regulations related to each specific appeal during each call. The next slide, please. This is some provider feedback. This is what they're saying. So if you would like to participate in the telephone discussions with C2C, don't let this opportunity pass you by. mail, email, or fax C2C to participate because it is a voluntary, you can volunteer to participate. But if you receive a letter from C2C, which is going to be on the next slide, you can receive a letter from C2C. They may select you to participate. And if you do receive a letter, make sure that you respond to the letter in a timely manner. But if you're not the person that receives the mail, make sure that you tell the person that does receive the mail that you're looking for a letter from C2C. And if they do receive it, to get it to you as soon as possible to take advantage of this opportunity. And we do have Emily Barnes and Amy Fight from C2C on the line. If there's any questions, Bill, they just dialed in. So
Yeah.
if you can unmute their phones, if there are any questions.
I think I did for Emily. I'm not seeing anything come in, but we'll give it just a second here.
Okay.
I did want to go back to one of the slides.
Hi, this is Emily. Can you guys hear me?
Hey, Emily, we sure can. Yeah, it doesn't look like
Okay.
doesn't look like there are any specific questions coming in right now, but
Okay.
I'll let you know here if something opens up in the next few minutes. So I guess one of the questions I wanted to ask for some of the providers on the call is slide 62. You talked about reasons why cases aren't reopened and whatnot, and 69% were because requested info was not submitted. And I just wanted to make sure, only because this has been a point of contention with payers in general over the years, is providers are sending information and sometimes not being received either at all or timely or whatever. And I just wanted to ask about that and see if anybody out there on the
Yeah,
call.
absolutely. So let me make sure that we clearly understand there are two distinct components to this demonstration. So the telephone discussions that Sandra and Marlene were talking about, those telephone discussions are held on incoming appeals. Those are appeals that we have not made a decision on yet. Those are ones that were denied by the MAC, and now they have come to C2C. They've come to reconsideration level, and we have not made a decision on them. Those are the ones that a telephone discussion are held on.
Yeah.
Then the other component of the demonstration is the reopening process. And that's the slide 62 that we're looking at, that pie graph. So 62, so these are the ones that are currently sitting at the ALJ. We take a look at them and we say, okay, you know what, if we could get one more piece of documentation, if we could get, you know, whatever it may be that we're needing to cure claim payment and find this favorable and get the, you know, effectuation out to the provider, if these are the ones that we're talking about here. So where it says requested info not submitted, we sent out a letter to the provider and said if we could get, you know, the lab results for this, you know, test, we could pay this.
Sure.
Or we could reopen, we could remand this back from the ALJ, we could reopen it and we could pay it. So what that means right there in that 69% is we sent out those letters, we gave the provider 30 days to get it into us, and nothing was submitted back.
Okay.
And I know that Sandra and Marlene were sharing too. So we're working one step ahead of the ALJ. We're constantly in communication with OMHA as far as what they're scheduling. So we're staying 1 quarter ahead of what they're scheduling so that we can potentially get these resolved before they would schedule the appeal for a hearing.
Okay.
So if you get that letter, then know that you're probably, you know, not far away from being scheduled for a hearing, but we're trying to get it resolved prior to that.
Yeah.
And that's what makes it the two-phased approach to reducing the volume that's at the ALJ.
Okay. Any other questions anybody has? Any of the attendees on the call? Any other questions for Palmetto GBA today? We ran long, but it was good information, a lot of information. And let me just say again that the information will be shared on the screen, let me go to this real quick and just show you, if you guys have this on your screen, where the presentations can be found. So this is the Georgia HFMA website, and this is the media tab. If you drop down to the document library and then go to scroll down to in case you missed it, double click on that. That opens up several folders. Go to 2021, double click on that. And what we'll insert right here is a spring payer forum folder. That should be up there probably in the next couple of days. So today's presentation, as well as a recording of the webinar, will be included for each of the days this week if you need to go back and reference it or you need to pull the documents or whatever. So I hope that's helpful for everybody.
Bill, this is Marlene. Let me go ahead and add, I've been looking for that information. Nothing I can find is giving the okay to use remdesivir for outpatient basis.
Mm-hmm.
It's only discussing it as far as inpatient. So to answer that question, I don't see anything and don't know of anything as of this current moment regarding remdesivir for outpatient COVID-19 treatments.
So to use it and get reimbursed for it, the patient would need to have been admitted.
Right.
Okay.
And there's a dedicated web page to that on the CMS website.
Okay. Okay. All right. Let's see here.
Bill, this is Emily. Can I just add one more thing?
Sure.
I know that I believe it was Sandra or Marlene, one of them, at the end of the presentation was saying that if you would like to participate in the phone discussions, you know, they gave that email address, that ADEMO feedback email address, or our fax number there, or the website. But real quick, to everyone on the line, if you're wanting to participate in a phone discussion and you're submitting that reconsideration request into C2C, you can write it directly on that reconsideration request that you're wanting to hold its phone discussion, or you can include a cover letter that says, I want to participate in a phone discussion for this appeal. That's probably going to be the best way to participate if you're wanting to participate in a phone discussion for your appeal.
Okay. Great.
Yeah.
Did anybody else have anything to add? Charles, we appreciate you being with us today. Marlene, appreciate you being with us today. Sandra, thank you as always. And to Emily, to you as well for joining us today for this call. I think it's a good start to the week. And folks, we will be back here again tomorrow at 1 o'clock we'll include Gainwell Technologies to talk about Medicaid. And I hope that you'll be able to join us. We had a good turnout today, and I'm sorry for any of the technical issues, but I think we were able to manage through those pretty good. So yeah, thank you. And with that, I will thank everybody for their time and hope you have a good rest of the week. We hope to talk to you tomorrow.
Thanks, Bill.
Uh-huh.
Bye-bye.
Bye-bye.